All right, good morning, everybody. Our talk today is going to be about fluid management in pediatrics. I am Usama Mohammed. I am one of the pediatric SHOs covering orthopedics in G3 and University Hospital Southampton. It is such a vast subject, but I've tried to make it as concise and as brief as possible. So starting to talk about fluid management, first we need to talk about the normal physiology that I am sure that everybody of us know. So our body fluids are comprised mainly of two main components, the extracellular fluid and the intracellular fluid. The extracellular fluid comprising around 20 to 25% of our total body water, with the main electrolytes being sodium and chloride. And the main components of the extracellular fluid, as we all know, is plasma, which is in the intravascular fluid, and the interstitial fluid being the extravascular portion of it. So the plasma volume can be mainly altered by conditions such as dehydration, anemia, polycythemia, heart failure, abnormal osmolality, and hypoalbuminemia, while the interstitial fluid is largely affected by the conditions that might cause edema, which are like heart failure, liver failure, nephrotic syndrome, and also hypoalbuminemia. The other main component is the intracellular fluid, which comprises of around 30 to 40% of our total body water, so around double the amount of the extracellular fluid, with the main components are, main electrolytes are the potassium and phosphate, and can be mainly altered by the osmolality of the extracellular fluid. So think about the functions of the fluid therapy are largely to correct the losses of the body water, or correct any electrolyte disturbance, to restore the blood volume and maintain the osmolality, the pH, and electrolytes, which lead to restoration of the normal physiological functions of the organs. Talking about the types of fluid therapy, we have two main types of fluid therapy. The first is the oral fluid therapy, famously known as the oral rehydration solution, with the main indication being in mild to moderate dehydration, with its main cause as gastroenteritis. The advantages of the oral fluid therapy is that it is readily available, very easy to use, and it's very effective. It's actually as effective as IV fluids in treating mild to moderate dehydration. And it can help treat vomiting itself. I know that vomiting is a big no to medics usually when it comes to oral fluid therapy, but it actually can treat vomiting itself, especially when the vomiting is due to electrolyte imbalance. And it is obviously less traumatic than the IV fluids because it does not involve using needles or stabbing children. So the other main type is the IV fluid therapy, with main indications being moderate to severe dehydration and sometimes in mild dehydration as well. And other indications being hemorrhage, electrolyte imbalance, and inability to maintain oral intake. This takes us to talk a little bit about the IV fluid therapy, or plasma expanders. We have two main components, two main types of plasma expanders, them being crystalloids and colloids. Crystalloids are the mainstream IV fluids that we use every day, largely, like saline with its different concentrations, whether it's being normal saline, half normal saline, or hypertonic saline, 3%. The other crystalloids are Ringer lactate and dextrose, also with its different concentrations. The advantages of crystalloids are that they are easily stored, they are reaction-free, they do not invoke hypersensitivity reaction, as is the case with colloids, as we will see. and they are pretty quick in correcting fluid and extracellular fluid and electrolytes losses. There is a disadvantages are being that large volumes are often needed to correct the losses, which can subsequently lead to edema, unfortunately, and they can themselves cause some electrolyte disturbances if they are not used correctly with the correct concentration, and they can leave the body quick, so often longer periods of therapy will be needed. The other type is the colloids, and these are type of fluids that contain usually plasma proteins such as albumin or other colloidal molecules like dextran or gelatin or others. And the main principle is that they use the oncotic pressure to maintain the intravascular volume through shifting the fluid from the extravascular to the intravascular portion. And the main disadvantages is that they are relatively expensive, and they can, like we said earlier, they can induce hypersensitivity reactions to the molecular to the components, to their components, and they sometimes can actually manipulate or alter the platelet number and cause some clotting disorders. Next are we are going to talk about the main principles of fluid therapy, and we have two main principles. First is the deficit therapy, and the second is the maintenance therapy. The deficit therapy is largely the amount of fluid that is needed to correct the acute loss of body fluids, and this is calculated through the equation percentage of dehydration times the body weight. Obviously, the percentage of dehydration will discussed later. And the maintenance therapy is the amount of fluid that is needed just to maintain the circulatory volume, and it's calculated in children as using the usual method, holiday cigar method, which is the first 10 kilograms, 100 mils per kg for each kilogram, and the second 10 kilograms from 10 to 20 kilograms, 1000 mils plus 50 mils per kg for each kilogram above 10. And if the child is above 20 kilograms, we use 1500 mils plus 20 mils per kg for each kilogram above 20. This is the water maintenance. The electrolyte maintenance is usually calculated as for the sodium is 2 to 3 millimole per kg per day, and for potassium is 1 to 2 millimole per kg per day. So in our approach to a case of dehydration, for example, first thing that needs to be evaluated first is the percentage of dehydration, and by far the most reliable method is the clinical evaluation. So it's classified into mild, moderate, or severe according to the symptoms or signs that the child exhibits. Mild dehydration is loss of body fluid by around 3 to 5%, and usually children can look normal when they have mild dehydration. Maybe sometimes they will be having some increased heart rate, mild decrease of urine output, some thirst sensation, but otherwise the physical examination would be normal. In moderate dehydration, which is comprised of around 5 to 10% fluid loss, they start to exhibit various symptoms and signs, including tachycardia, little or no urine output. They can start to be irritable or lethargic. They can start to have sunken eyes, sunken fontanelles. Their mucous membranes start to become dry. Capillary fill time start to be prolonged, and their extremities can become clammy and pale. And in severe dehydration, this is where we find their pulses to be rapid and weak, almost no urine output, blood pressure starts to fall down, and the skin turgor starts to become delayed and the general consciousness level become altered. So using this clinical evaluation, we can estimate the deficit therapy using the equation that we mentioned earlier, percentage of dehydration times the body weight. So dehydration types are unfortunately not straightforward. There are 3 types of dehydration according to the main electrolyte in the extracellular volume, like we mentioned earlier, which is the sodium. So in our approach to dehydration, the second thing we need to do after estimation of the dehydration percentage is to look into what type of dehydration that we have. Is it isonatremic, is it hyponatremic, or is it hypernatremic? Isonatremic is by far the most common type of them, because when we usually lose body fluids, we tend to use electrolytes as well. But fortunately, it is the more easier to correct because it can be usually corrected with normal saline or lactate plus dextrose 5% to supply the minimal calorie requirement throughout the day. And it is calculated by, like we mentioned earlier, the deficit and maintenance fluid therapy that is needed. The deficit being the weight times dehydration percentage, and the maintenance using the Holiday-Segar method. And the administration would be usually it would be also according to the type of the dehydration. If, for example, the patient is severely dehydrated, that it is nearly shocked, we would be the first phase would be rapid restoration of circulatory volume by giving fluid boluses, and then administering the deficit therapy. As in the first 8 hours, we would be giving half the amount of the deficit plus 1/3 of the maintenance therapy. And over the next 16 hours, which is phase 3, we would be using the other half of the deficit therapy and the remaining 2/3 of the maintenance therapy. If there is ongoing losses, as in diarrhea or vomiting, we would be replacing the ongoing losses as they occur. Next is the hyponatremic dehydration, and this is usually seen in children that have, for example, gastroenteritis, ongoing diarrhea or vomiting, and they would be feeling thirsty. They would be drinking large quantities of water or any other hypotonic solutions, in which case the loss of the sodium is greater than the loss of the water, which means that the intravascular volume, intravascular fluids would be hypotonic, which leads to shifting of the water from the intravascular to the extravascular, or from the extracellular to the intracellular space, which results in increased brain volume, subsequently leading to convulsions in some cases, in some severe cases. The shifting of water from the intravascular volume would actually lead to even greater degree of shock. And this can be corrected using hypertonic solutions like saline, 3% saline, hypertonic saline. But it is usually, these cases are usually done in PICU because they need very, very careful correction, especially the sodium level. It needs not to be increased over 12 millimole per liter per day, 24 hours. Otherwise, sometimes it would cause the undesired effect of the central pontine myelinolysis, which is a very serious condition. The last one is the hypernatremic dehydration. Usually, it's seen in patients that are unable to take fluids orally, whether it be because of lack of access or poor thirst mechanism. Sometimes some patients with neurologic impairment, the thirst mechanism are impaired, and so there's no knowing of how to correct the fluid loss that is going, or the dehydration that is going, that leads to accumulation of sodium levels leading to hypernatremic dehydration by the means of the water being shifted from the extracellular space to the intracellular space, leaving the sodium behind, which sometimes partially corrects the intravascular volume, which, coming to think of it, actually, this type of dehydration is the most serious because when the water shifts extracellularly from the intracellular fluid just to by osmotic pressure, this can sometimes mask the hypovolemia that is going on. So sometimes these patients can preserve the urine output a little bit longer, and they do not exhibit the classical signs of dehydration like tachycardia, or the tachycardia wouldn't be as severe or as obvious as it should be. So clinically, they won't be exhibiting these signs, and sometimes they do not receive the immediate care that they actually, or the immediate correct care that they actually need. In other cases, hyponatremia can cause fever, hyperreflexia, and seizures, but these are usually when the sodium levels are very, very high, above 165 or 170. This type of dehydration should also be very, very slowly corrected according to the sodium level. Sometimes it can take up to several days when planning. When planning for the fluid therapy, we actually usually plan it over several days. Sometimes it can reach up to 4 days to correct the sodium level, and it should not exceed 0.5 millimole per liter per hour when trying to coming down on the sodium level. This, of course, to minimize the risk of cerebral edema. Deficit and maintenance fluid rate in this in this type of dehydration is usually constant over the whole period of correction. So we don't give the deficit therapy like we did in the other types of dehydration. For example, we said half of the deficit therapy would be over 8 hours and the other half would be over 16 hours. And the maintenance 1/3 over the next 8 hours, the first 8 hours, and the remaining 2/3 would be over the next 16 hours. This is different here. The deficit and maintenance fluid are both calculated and added together, and they are both equally will be distributed over the total period of correction. And that is it.
Osama, can you hear me?
Yes.
Lovely. That was incredibly thorough, incredibly clear. Your slides were excellent, all very nicely laid out. You spoke like you sounded like you were a paediatric intensive care consultant with the knowledge that came out there. So very, very informative. Well, very well done.
Thank you. Yes.
I don't know if there are any questions from people on that. There can be some very good, simple principles, but also as fluid management, particularly in unwell children, when you need it, can get very complicated, as we've seen. So if anyone's got any questions about some of that.
It's even applicable for the elderly patient care with regards to sodium and water. And SIHDH is one thing that when I was in my young years, I always struggled to understand, and how the hypo, the water volume without any kind of sodium concentration can affect the overall hydroelectrolytic balance of the patient. So that's quite good. Yeah. Thank you.
Thank you.
Silence from the room, so that's great. Osama, thank you. Do send some feedback for that to any number of people who can give you a little assessment thing if you wish, if you need that for training logs and stuff.
Oh, thank you very much.